Let's say. Reads here. For the record, we don't have anyone, hearing remotely. We don't have any, members of the public from Wingers. We do have someone that, Melanie brought with her. So I'll start with public comment. Any comments? No comments, okay. Okay, approval of the agenda, so we don't yet have a forum, so we're just gonna go with the agenda. I know, Carlin's running like 5 minutes late, so. All right, we'll, table the approval of the minutes to June 5th. Do we have any member announcements? Any member announcements? No? Okay. Chair report. I have nothing. Bylaw review and approval, we'll hold off on that. Any correspondence?
None.
Oh, it's gonna be funny, because this will be really funny if we like just all leave and Carlene gets your announcement. No correspondence. So we're skipping 8, skipping 9. Board of Supervisors report, nothing. Criminal justice report, I can say a few things for Chris. I know they're still working on trying to get young adult scores up and running, and that's going to be another collaborative work that's been funded by the Community Corrections Partnership to address individuals criminal justice involved who are age. They're still working on that. And we had a couple of graduations. We had a very exciting graduation last week for addiction intervention court. This was a really interesting case. This was a guy named Renwick Gray. Renwick, at the age of 16, committed a very serious crime in West Sacramento and was sentenced to, I don't know, not a life term, but a very lengthy term. Okay. He served the term. He basically grew up in prison, you know, and then fast forward to his mid to late 20s. There's a new law now on the books, as of a couple of years ago, which some of you may have heard of, called prosecutor initiated sentencing, which after all the appeals are final, it gives the DA a vehicle to recall sentences. And the DA can want, the idea being sentences that no longer serve the test of time. And there could be 2 main reasons for that. One, the DA can look back and say, that was a really, really long sentence and we probably wouldn't have done that today, you know? And or B, he's earned his right to get out early. So with Renwick, he was young, and he had done really, really well. We almost were finished. Carly, we almost finished, we're gonna leave.
I've heard.
Yeah.
What's the tip then for you to review?
Talking about Renwick Gray, and so his sentence, I don't know if it was long, but he was very young and he had done really, really well. And the Senator's office did a great job in putting together a big packet on what he had done, and the DA looked at it and decided that they would release him. So we released him probably 2 years ago. And then the problem with when these individuals get released is they often don't have a lot of support. Someone like Renwick, you know, who basically was playing when he was like 16 or 17, well, 18 he was in junior hall, but you know, how do they cope, right? So he explained this at the graduation. He said he really he didn't do drugs before, but he started doing drugs when he got out, and that was a medical role. And then he had a break. And we get this police report where he's arrested because he had taken a baseball bat and was hitting cars and fought the police. And we were beside ourselves. Like, what are we going to do now? And at the graduation, I told him, you know, you are responsible for one of my highs as a DA and one of my lows as a DA. The highest today is graduation, the low was that day, when we were like, are we gonna send this guy back to prison? But we decided to put in an addiction and detention part. And it worked really well, he was in there for 2 years, did really well, he's a bus driver for Yellow Bus. And graduated, and this guy is like, smile always across his face and worked really hard. So that was a really exciting day. So I know we've said this before, but and we probably should get you the notices on these graduations that usually happen on Mondays or Friday, depending on if it's AIC or MHC at 1:30, but they're really, really powerful. And we're going to
If you see that online.
yeah, we can.
Yeah.
We can, we know that, and I'll work on that. I'll work on that first.
And then we can build it into our planning.
Yeah.
The other thing I think would be really cool for some of you guys is to have these graduation and like a video that we can post onto our site.
Yeah,
People can see like the successes.
yeah,
And it just kind of really promotes that as we're going through. So if we could do something like that, it would be good.
okay. Can you put that in the minutes in like caps, you know? Get this for graduation dates at least a month out. Thanks. All right, are there any ad hoc reports?
We've tried to meet, program committee, we've tried to meet, it's been really difficult, it's been. We haven't met, although we've communicated online through email. And we are ready, and I need to make another meeting with you, because we really would like to get started, we think. We'd like to do like 3 visits, like we talked about in strategic planning. And so we need to get the forms and the documents approved. So I do need to set up a meeting with you. And everybody kind of agrees that they're fine the way they are. The committee kind of looked at them and we've, so we'll set up a meeting with coming in Samantha and move forward.
Great. We know what sites we're using?
Nobody has come up with a definite, we don't know what sites yet. We're talking 3, and my suggestion was, since we were so interested in 5150 and people being hospitalized, maybe programs that are following people after their discharge or trying to keep them out of hospitals, those kind of programs we were thinking about. I don't know, it's.
Sounds good.
Someone add anything or anything?
No, I'm thinking the same thing, and maybe do adult, maybe a youth, we have these facilities as well.
Yeah, I mean,
I'm not familiar with all the facilities that we have in our county.
Not anywhere near the same
Yeah.
magnitude of adult system of care, but for, yeah, I mean, outpatient certainly, you know, but in terms of like. I'm not sure what you're interested in, but.
Do they have to be in the county?
I don't know, I think there's a lot for us to sort of sort through around the site visit, you know, I mean, so.
yeah.
And in terms of like, really what the ideal is that you're hoping to be able to see. That would help, I think, maybe offer some suggestions of what programs might be most beneficial.
I know for me, I'm interested in the case management that goes on there, that's what I'm interested in. I don't know.
I think I'm more interested in just as an educational perspective, just to kind of go in. I don't really have any expectations on their part, other than just.
Yeah, and I know Brad is, yeah, and Brad,
I just wanted to add to that, I wasn't at the beginning meetings.
No.
I kind of came into it after, so I haven't really had a chance to look at like what's our purpose and how are they interview us when we go in, and I guess. I was a little concerned about that, but I want to make sure that when we do go, that they understand that we're not there monitoring them, this is not a monitoring tool or monitoring review, it's more of a just a site visit, how are you doing, you know, we just want to know. How's your program working, are you know, are they happy here, or, you know, and then we can report back to the board on. our findings.
Yeah.
Although I shouldn't use that terminology, that's kind of a monitoring word.
And I wonder if even to communicate with our providers or whomever it is, you choose to go look at it, we can premise it with. An opportunity for them to show off the program.
Yeah.
To sort of show off for you what services are provided for our
That's
community.
a good way to
Yeah.
bring
Yes.
it up.
Yeah.
I think we're almost at a quorum. Feel it.
It's gonna be coming.
Feel like we're close to quorum. Feel it.
You must have got a text.
You did.
Oh. By the time you pick up your more birthday.
Okay, so I believe this is too much to ask. So by the next meeting, you will, the ad hoc committee will meet with the staff. And then you'll have your 3 selections and strive to schedule one visit. Third one will be the whole part.
Yeah.
Is that,
Yeah.
okay?
I think so, I mean, I think it'll, I think it will depend on the conversation, I'll just say in the previous conversations, my. Worry was that there was a sense that this is some sort of audit of the providers and that there was gonna be a report written and published and posted online. And so I wanna make sure that this body's very clear on what the purpose is and how that information will be used, because to be, clear, at least for, and you guys aren't associated with necessarily that's Health and Human Services, but it's not a part of like a provider's contracts, right, to have site visits from the local mental health board, for example, and so I could see it. I think without the right scaffolding for this and alignment around the purpose and the vision, I could see it creating some anxiety for our providers and some confusion, right, about the purpose, or like, is there gonna be some report that's posted on the internet forever and ever, to live on the internet forever, you know what I mean? That has some negative perceptions of the facility, so I think that's where we wanna just talk through some of the site visit pieces and what the next steps then are.
Do you wanna meet with our whole team or our whole committee or?
We can, yeah.
What do you feel? Do you wanna?
Sure, yeah,
Yeah.
might be good just to talk through a little bit more, yeah, so that would be great.
And we can also talk about sort of confidentiality as well. and
Yeah.
So that we ensure that we about that. That's the other
Are
piece.
there releases required, like when people go in for site visits? No, when,
Only if you're going to do something that's identifiable.
okay,
I mean, that's if, for example, you're gonna say, Susie Smith said that. But if you're gonna do it in a more general fashion where no one can be identified, there usually isn't the need, or if you're gonna take pictures. But if you're talking to someone in general about how they feel about this service or that service, and you're not going to identify them, then you don't usually have a paddle.
What we wanna do is. Make sure that the provider has adequate notice.
Yeah,
My apologies, what we wanna do is make sure the provider has adequate notice, that way they can prepare themselves for the visit, right? And then they can inform any clients who might be present if they would be willing to participate.
Yeah.
Yes.
voluntary have to be on.
Right,
Yeah.
so then it's really not a problem here, right? There would be an expectation that anything that you, any confidential information that you were receiving would remain confidential, so I imagine there might be some sort of a, not necessarily a release, but just like an agreement to keep things confidential, but it would really be potentially a client themselves who would be sharing information with you, right? That they're at their own discretion, right? And that they have their own consent to do that. So I think just like Carmen was talking about in terms of like scaffolding and getting everything prepared. We would want to have time to have that conversation with our contracted providers. If they understand what the intent is, they can prepare themselves and their staff and the facility and everything that's on for this effect.
Okay, so Christina for the minutes, deliverables are ad hoc committee will meet with staff for the next meeting, select 3 sites and if possible, set 1 site visit date. Okay, any public comment? Okay. All right, so we're gonna go back up to, let's go to approval of the agenda. Can I get a motion to approve the agenda?
I'll make a motion.
Oh, okay, I don't see him, but it'll be perfect, okay.
It's so bad.
Maria makes a motion, John seconds it. All in favor, say aye.
Aye.
Opposed? Okay, approved. The minutes, can I get a motion to approve the minutes from June 5th? Motion to approve the minutes from John. makes a motion.
Second.
Nikki second. Any corrections that need to be discussed? All in favor, say aye.
Aye.
Opposed? Abstentions? Okay, that passes. Bylaws review and approval. So we discussed this last meeting, we tabled it, so that we send out the minutes where it would be more clear on the changes. Do you want to talk about it?
Yeah, I went ahead and made a version with the annotations. I don't think the annotations printed out. So did everybody get a chance to look at them when they were sent to you? Okay, all right. Well, I can just run through them then.
Yeah.
Changes?
Yeah. I mean, first of all, I did note that I didn't annotate anything would change because it was like a grammatical or a formatting error or something like that. So the first one we have is actually on the first page where the language is in any facility. So it's duties and responsibilities, number 1. We added on the part that starts in any facility within the county or jurisdiction. And that was just to make it match the welfare institutions code. And most of the changes we made were just to either make it match the welfare and institutions code or board of supervisors policy or something like that. The next change is on page 2, where we updated where it says California Behavioral Health Planning Council. And again, that was just number 7 towards the top. That was also just to make it match the welfare institutions code. There was another one like that. On number 8, again, it was just an update to match. The third one on here. It's in number 9, well, after number 9, we deleted 2 redundant sections about the relationships with the board of supervisors and the county mental health director. We just took it out because we already had it somewhere else. Another place where we changed it to comply with welfare institutions code was under membership, where it's 1B3. That was just because they added the language about the veteran advocate, so that was changed to be updated. Number 5. Let's see, so that's under membership number 4, and that's just moving things around. That's not even a substantive change. And then the last one on that page is membership number 5. And that's another one that we updated to comply with the welfare and institutions code. So I don't know if you want to be reading off of the things that we just changed.
Didn't we discuss something about forming ad hoc instead of having?
That's later in the bylaws. Yeah, that was the biggest change.
Yeah.
Yeah, the 2 big changes that really matter are we dropped all the standing committees, and then because we no longer had standing committees, we no longer had chairs of standing committees who needed to be part of an executive committee, so we deleted that too. So I don't know if you want me to keep going through the details or if just based on knowing that those are the 2 big changes. We just really
To make sure that we had the means to be able to do what we needed to do by having ad hoc committees, but we didn't want to have standing committees, the ability to continue that work.
Yeah, and we already voted saying we were gonna take out the standing committees, we just never voted on the full bylaws.
So we voted on doing it, we didn't vote on the change to the bylaws, so now the bylaws are conform with the vote we made about. And not having some. Okay.
Should I go on?
No,
or
these
is
are all-
this- Yeah.
This was sent to everyone, people, we've been working with this for months, people should have read it, and if there's a problem, people can speak up, but other than those two changes you just mentioned, everything else is just conformed with the.
Yeah, pretty much, and everything that we've done as we've gotten to each draft, we did the red lines, it's just, when we came to the last meeting, we only had the final bylaws, we didn't lay out everything that had been changed over those last year. So that's what this was for today, all about.
So can I get a motion to approve? Yes.
At one word, I fudge. Under the quorum section,
Where's that?
it's section 6. Just, I think you could say it's somewhat majority.
Well, this was something that was changed when Teresa went through it. It used to have, the quorum used to be, I think this is majority, and Teresa was supposed to be the majority plus one. So I don't know.
That is a simple majority.
Well,
The simple majority is half of those voting in present plus one. That's the definition of it.
So this is just 6 of one, half a dozen. of the
Yeah,
other,
you
right?
just said that the word simple precludes you from saying this needs a 2/3 vote, this needs a whatever vote.
Well,
That's,
this precludes it too. I mean, I'm not opposed to what you're saying. I'm just saying, do we need to, because this says one more than one half the appointed members. So that would be the
That's-
same as a simple
that's
majority.
a quorum.
oh, you're saying a majority vote of the
Oh,
members
I'm
present,
sorry.
and you're saying it should be a
Second
simple majority.
Oh,
Yes,
yeah.
that's how we
Oh, I
should
see, I
change
see.
that.
Okay,
Okay, we
so
can do that.
add the word simple.
Yeah,
Okay.
sorry, I misunderstood.
I misunderstood you too. Thank you. Okay, so can we have a motion with that change?
I'll make a motion.
I'll second it.
So the motion is to approve the amendments.
With the amendment.
The one change being in the second sentence of section 6, it'll say simple majority rather than simply a majority. Did we get something? John, did you get that?
Yes, I did.
Okay, all in favor, say aye.
Aye.
Opposed? Abstentions? Thank you. Thank you so much. Chris missed it. Yeah, so we're gonna be doing this,
No, I was just gonna. Okay, that's good.
we're gonna be doing this again next year for the changes due to Prop 1.
Are there three maybe for some-
Prop 1 is
Yeah,
actually-
back up.
Yes,
Oh.
well, like, probably gonna change the name, behavioral. And are there other changes?
That's the board had that in-
Yeah, that's, I think you have to add,
You sent us a whole list.
representative, transition issue.
Transition, yeah, right. Okay.
But doesn't the board have to change their name? As opposed
Yeah,
to.
that's what he was saying.
Oh,
Yeah.
The board supervisor? That's a good question.
Yeah, I think. county council can help
What
with
would be,
that.
what would you think it'll change?
It'll just be local behavioral health board meeting, or local behavioral instead of now.
Instead of your.
So we probably should make the recommendation.
Yes, I think so. We'll talk to county council. Thanks. Thank you. Okay,
Might want to name ourselves tomorrow, but
I know, right?
nobody else will for it.
Okay, we're up to time set again.
Yeah.
8, Arlene.
A.
Oh, yeah.
I'm gonna have to switch the screen because that's not gonna help you.
Our presentation today will be regarding a number of audits or reviews that we've had just in the last 6 months. The purpose is to present either the findings and or recommendations to this body. It is a piece of information that I think helps inform your duties as a local mental health board, and the timing just so happened that we've gotten several final reports recently, and so happy to be able to walk through these. And I'll have Sam and or Tony chime in, probably different pieces throughout the presentation. So we can just go page down, Christine. And so the three audits or reviews that we're going to cover are the external quality review. And so that is conducted by the external quality review organization.
So can I stop you for a moment?
Sure.
I'm sorry. I just got a text from Christian, maybe it looks like she's turned the log on.
Yes.
Christina? Do you see Christy Perea?
There it goes. No, I don't see her in there. Is she trying to join?
Yeah,
I don't have anyone in the waiting room.
Kimberly accidentally went to the wrong location. She'll be here in 20 minutes, which is 2 minutes ago. Okay, okay, I'm sorry.
So the three audits or reviews that we'll cover are the external quality review. The DHCI, Department of Healthcare Services, what they're calling now the engagement audit, but it used to be called the triennial. And it previously just reviewed our specialty mental health system. But now it is a trifecta of a review. And so they review our specialty mental health, our drug medical health organized delivery system, and then also our substance use or substance abuse block grant. And so it is a much more involved process than it was previously, and this was the first year that they've done this combined audit. Very resource intensive, so we'll talk about that when we get to it. And then the last was a very recent mental health services act audit. We actually just got the findings this week, so.
Yeah.
I'm not presenting on the other two, but we got the final report for the MHSA audit, and so.
He says I'm using the link in the agenda. You want to send another link?
Yeah, I'll send it right now.
So the first review is the external quality review. And actually, I'm probably gonna have to, I'm just to give an overview. Oh, can you move to the next slide, Christine, sorry.
Yes,
You're
that's
jumping
okay.
a couple different things right now. We're just gonna give a high level overview of what the process is for the DQRO. And before Sam came back to Yolo County, she was the director of the DQRO, and so she's very familiar with their process. But it is a review that previously used to be done on site. It was held entirely virtually now. And they review and validate our performance improvement projects. They look over our local data and our medical data. They do a review of our information systems capability. They validate our performance measures, and then they offer technical assistance and training. So Tim, do you want to say more about the DQR?
I've tried to kind of like put that past.
Sorry.
Put that part of my life in the past, but let me see if I can recall some of it. It is part of the federal requirement for all states and all specialty mental health plans and drug medical organized delivery system plans, because we are a managed care provider for Medicaid beneficiaries, specialty behavioral health care, and because of that, we're required to do an external quality review. And as Carleen mentioned, we're required to look at performance. I'm slipping back into that language. They're required to look at performance improvement projects, both a clinical and a non-clinical performance improvement project, looking at various types of performance measures. The information systems capability assessment, as Carleen mentioned, essentially, how do you know what you know, and how are you using data to inform the decisions that you make in your system? And they're looking at three specific types of areas of care. The first being timeliness of services. How long does it take for somebody to get in for the care that they need? Another is access. What kind of access to care is there for a person with Medi-Cal to be able to receive their services, both in terms of geographic access as well as cultural access, and looking at health equity. And then looking at access, timeliness, and quality, overall quality, in terms of communication of the system, in terms of outcomes, both functional and clinical outcomes, and then and how the system utilizes data.
And so I'll just give a high level overview of some of the watch how we need to know. And so, you know, a part of this process is that they hold consumer and family member of consumer focus groups. And so, can you go to the next slide, Christina? So the first thing I'll just share is just some quotes from that portion of the review. So there, and they weren't all positive, so I'm not only sharing the positive comments, but as you know, one person said services have been a godsend, another person said they've introduced helpful charts, new ideas, and ways to do things while respecting my background and beliefs, and really that was particularly apparent. Of the individual receiving specialty mental health services. Another comment, my provider was instrumental for setting up an IEP, an individualized education plan with my school. Also Victor Services was amazing. And then there was another quote, that this one was a bit more sort of constructive criticism. Peer parents would be helpful and support groups for those who are not foster parents. Overall, the EQR summary of the findings or feedback from our clients and consumers was that both groups really shared an overall positive view of the usefulness of the services they've received. They report the services were helpful in their recovery and that staff give them hope and are respectful of their cultural and personal beliefs. On the other sort of side of the coin, there was an awareness of staffing issues that result in staff having a burdensome schedule. So, you know, clearly, I think our staffing challenges, vacancy rates for us and for our provider, contracted providers, that in some way in the focus groups, you know, there was some report of how that was felt by the consumer, right? Whether it's through difficulty scheduling or just experiencing maybe feeling or seeing the burnout, right, in their staff. However, they said they all agree that they continue to receive the services that they needed, even with any staffing challenges. Can you go to the next slide? So the strength, I'm sorry, I just cut off at the bottom there. There were a number of strengths that were noted for our system. First, the external quality review team found that our integration, so being a fully integrated health and human services agency, provides some behavioral health efficiencies for both our children's and our adult system of care, which they noted as a positive quality measure. They noted that as a mental health plan, we had implemented our health information exchange, and that is an important step toward interoperability. So that's around information sharing and data sharing. So that's an information system strength. They also noted that we had implemented the business intelligence solution. Sorry, I switched the order on here and on here, so when I'm looking back and forth, they're not matching. So I can format it and then there's a few way on there. Which helps us with monitoring and analyzing some measures that we're required to measure, which are known as HEDIS measures. Quality and information systems strength. Another strength that was noted is that our adult native forensics program continues to collaborate with the county criminal justice system, and that they've seen increased access to mental health court, addiction intervention court, and other diversion programs offered by the district attorney's office. So those were noted as access and quality strengths. The next was that our stakeholders noted improved transparency and bi-directional communication with leadership that invites them to the table for planning of programs and services, and that was noted as a quality strength. And then the last was, and this is one that's cut off, I'm sorry, that as a mental health plan, we have strong billing practices and we have a low rate of denial for our claims over the last 3 years, and that was an information system strength. Next slide, please, Christina. And so they also identified several opportunities for improvement. So the first is related to our penetration rates for the Latino population. They noted that for the calendar year 2022, our penetration rates for Latino consumers, Medi-Cal beneficiaries were below the statewide rates, and that has remained largely unchanged for the past 3 years. So this has been a recurrent finding for us in our external quality review. And even with implementing some Latino specific, culturally responsive programs in the mental health services act plan, we haven't seen any substantial change in those data points. Yeah, Nikki.
How much below the state average are we?
I'd have to look at the whole report.
I mean, I'm just wondering if it's something that could be an artifact of carryover issues from COVID or, you know, if it's.
Yeah, go ahead.
Yes.
Or if it's noise in the system in some way, because. Looking at those penetration rates, most of the counties in the state are under where they should be.
Absolutely, and I will say one of the limitations to the data that the EQRO reviews is it's limited to approved Medi-Cal claims data. So it's only looking at Medi-Cal services, it's not looking at the entirety of the payer sources, so any of the grants, any other funding stream, so it's just looking at Medi-Cal, and of that, it's just looking at those claims that have been submitted and then were approved according to a particular pull date in time. And so it's one of the challenges, particularly when looking at the race and ethnicity data and looking at Latino penetration rate, is also, it doesn't reflect non-specialty services, and it doesn't reflect some of the services, as Carlene mentioned, that are provided through our MHSA programs like PEI, because it's only that Medi-Cal population. So it's not reflective of the entire community, it's just reflective of the community that has Medi-Cal.
It's just over 1% different. I just looked later, further back in the report, Nikki. So for calendar year 2022, the statewide penetration rate for Latino population was 3.51%, and for YOLO, it was 2.29%. So it's a small difference, but we've tracked below.
That's statistically significant
Yes.
for a population.
We've
penetration rate
we've
is
tracked
already that,
below year over year, and actually we
so
were
30%.
we're a bit closer this year, but I think that's only because the state penetration rate went down. Ours has remained almost unchanged. So in 2020, ours was 2.21%, in 2021, 2.24%, in 2022, 2.29%. So we're seeing just a fraction of a percent change year over year. Where you see maybe a little bit more fluctuation, and they compare us to other medium-sized counties, and then they compare us to the state. So compared to medium-sized counties, we're about 0.5% or less difference each year, about 0.5%. They're at 2.74%, 2.69%, 2.68%.
So when you're saying that they might be accessing other services, do you go back in time like that? Has there been any change to the type of other services they're getting? Yeah, so that we could figure out if that's what's going on, because these things are exist. Or something like that.
We haven't added any additional culturally responsive services. We had some that were long-standing, that weren't, and I think, you know, the intent behind at least one of those programs was to try and increase the penetration rates for our special, right? Because there's, you know, some of the purpose of PEI or other MHSA funded programs is to help link folks to specialty mental health. We're not seeing that kid off, and, you know, I've worked in another county mental health plan where we also had a larger Latino population, a large farm worker population, actually in Sutter County, Sutter Yuba. And at one point they had created a Latino outreach center, so a totally separate facility from the county mental health.
Each county has done that
location.
too.
Yeah,
They have both a Black Services Center and.
yeah, and the thinking behind it was around stigma, right? That's for some folks, there's a lot of stigma with accessing services at a larger site, and they also had the site located in an area for their Yuba City that was predominantly Latino, and even with that, they didn't see very substantial, significant increases in specialty mental health penetration rates. But certainly we're providing an important service for the community. So it's a tough, you know, and we'll get to the recommendations, but the recommendation around this is for us to just do some further investigation, sort of study, right, around these data points and to develop and implement some strategies to improve. So I think it's something we need to go back to the drawing board. Sorry, what was it?
I was gonna say, could it be something like ease of access to the services? It's hard enough to get
Yeah.
through if you speak English, but if you're speaking
Yeah.
Spanish, it's like no language, you're trying to get through all the other obstacles to actually speak with somebody. But sometimes it takes a long time
Yeah,
to get through.
Yeah.
And that could play a role too, and then again, okay.
absolutely. Yeah, and I think also, I think it's important to note too that changes at the federal level do affect our local access to services, you know, and we see that even in social services, so. We saw a huge decline in undocumented individuals, right, accessing social services and other really needed services. Under a different federal administration, right, when there was a lot of fear and issues around public charge. And so those things can really fluctuate too, depending on what's happening at a federal level.
What I think is notable about the youth program is that they are not located in government buildings.
Yeah.
And I think some of the reluctance that different members in different communities may have about going to a government site.
Yeah.
Gets alleviated when they're in a
Absolutely.
strip mall or.
Totally, and that's exactly what the Sutter program was, it was in a strip,
Yeah.
it was in a strip mall, it was
Yeah.
just like a kind of a large, open kind of office space,
Yeah.
it was wonderful. And it was utilized, certainly, you know, but I don't know that we saw, that it changed any access around the specialty model, but we certainly, I think, saw folks maybe at a managed care level, I mean, it's well, okay, the next was, around timeliness, so it said that. The feedback was with the exception of the first offered non-urgent psychiatry appointment. So that's a specific measure, right? First offered non-urgent psychiatry appointment, so with the exception of that one, our timeliness for service access warrants improvement. So we were meeting standards in that one measure, but for the remainder of the timeliness measures, our data showed that it warrants improvement. So that's the timeliness measure.
Where is that?
Yeah, address timely access outcomes and data tracking, which can you skip ahead a slide, yeah, okay. So this is the recommendation, I'm still on the.
Oh,
yeah,
go back.
yeah,
You're
Yeah.
that one.
yeah. Yeah, so there's a recommendation for each opportunity, so sorry, it's good, can you go back one slide?
Yes.
The fourth is, it notes that as a mental health plan that contracts out 2/3 of our services, that we have a particularly strong need for interoperability. And so the EQR noted that we had made some progress in the past year by joining the health information exchange. And that we had even onboarded some of our new providers into our electronic health record, so having contracted providers using our electronic health record to document and bill for their services. That's not the case for all of our contractors. It's not the case for most of our contractors, which is a big part of the problem that they're talking about here. At that point, and still, you know, we didn't have a great concept of how the HIE would be used operationally, and we didn't have a strong strategy for obtaining clinical data from our current contracted providers that don't document their services in Avatar. So there's a pretty big gap for our contracted providers who are not documenting in Avatar, which is our electronic health record, they're using their own electronic health record. Around capturing some of the data for some of these measures, even like the timeliness data. So some of our data may not be entirely accurate because it's very difficult to get the data from our contracted provider. So our vision, collective vision, is that we will have all of our contracted providers in our electronic health. We've seen it, and again, in Sutter, you bet, we had a model where all of our contracted providers had to use our electronic health record. And so we've seen it work. Sam's certainly seen it in other counties, you know, working for BHC, overseeing the EQR and seeing counties that had contracted providers integrated into their electronic health record. It's a huge administrative and resource lift, and we've been pummeled with new payment rates, new requirements from the state, and so getting our contractors into our electronic health record has gotten sort of pushed down on the priority list as a result, so. But we agree with this finding or this recommendation, and it is certainly a priority for us.
What's some of the reluctance to use our electronic health record?
For contracted providers, it's a number of things, so for some of, it sort of depends on the provider, for some of them. They're a much larger organization with other like physical health needs, and our electronic health record would be a secondary EHR that they have to use in addition to their own. So that's sort of the case for Communicare, for example, like they're transitioning to Epic right now, which is a very large EHR, right, used by all of our hospital systems, and so to then have to go into Avatar to document their contracts with us, they would have duplicative work, because they'd have to enter some sort of documentation in their own system and then document in ours. For other providers that don't maybe have this larger health system behind them, but they serve multiple counties, every county uses a different electronic health record. And so that was very difficult too. So if they were in our EHR, they might be using Anasazi instead of Yuba, but then they have to use Avatar and YOLO. There's been this new dynamic, there's a semi-statewide electronic health record that many counties have onboarded to, and that's called Smart Care. And we're very interested in it. We've seen a demo, we've got the quote, it's something we're exploring, but it's a huge undertaking to change electronic health records too. But that system's really being built for county behavioral health, and so there's a lot of advantages to that system. I don't know how many counties are using it now, 20 something,
Last count, I think we were at 24.
24, so almost half of our counties in the state are using it. And there's a lot of value to that piece too, so
Is there something that, happens as well?
yeah, and eventually what we would intend to do is make it a requirement of have to the county to use the EHR, but right now our EHR is not working as well as we needed to, and we don't have the internal resources to onboard our providers into the EHR as quickly as we would like to. And some of them want to be in our EHR, so for example, on the substance use side of things, on our drug medical organized delivery system, we have some providers, or at least one provider that I'm aware of, is very interested in being in our EHR, but because we don't provide drug medical health services ourselves as the county, we don't have a lot of the things built out in the electronic health record for that system. So there's a whole lot of work that has to go into prepping the system in order to onboard our drug medical health organized delivery system providers into the EHR to build through there, so there's a lot of challenge, so we are doing.
How does each collect the data right now on a monthly basis, or when we
Yeah.
have contracts? We're getting the money, we're signing the contract,
Yeah.
we're implementing the programs.
Yeah,
How do we receive, or how do you receive the feedback information, the statistical data?
yeah, so there's a couple of different things, so I'll say for their outcome measures, they're required to complete, we use that results-based accountability model, the RBAs, and most of the contracts require them to submit their data quarterly, and annually, but in terms of some of the timeliness data, we have a different mechanism, right?
Yeah, the timeliness data is definitely a challenge, and so we do ask our providers to submit their data in a couple of different ways. There are some spreadsheets that they submit their data in.
All spreadsheet,
Like in a
we send it to them, and then they have to follow.
And then also we receive, I don't know, you might want to speak of the claims data that we receive and how that gets imported or perhaps not, but our.
Yeah, I'll let you do your part.
I think perhaps the best way to summarize it is that there are a number of different workarounds that we have to get information from our contracted providers. And then some of the challenges, so like Nikki, you were asking about the Latino penetration rate, and I was talking about the challenge of it being limited to medical claims data. Ideally, we would have all of our providers in the same electronic health record, and we could then pull service utilization data for the entirety of the system. And right now, we're piecemealing that together with.
Creates a lot of opportunity.
You know what,
for error.
this sounds like something DHCS should do.
We agree.
Well,
To me, they learn everything else, why can't they do something useful?
Yeah.
So I've got lots of opinions, I'll do it, but, just to answer your question. It's complicated, right? I think, so I think it's like when we want to know about something, then we have to start building it out, right? So I think that in previous iterations of the administration, there were different priorities about what data collection looks like, right? And so, I think, like, so for example, like with the HEDIS measures, there is a way for all of our contracted providers to work with children, right? To input some specific data elements that we're trying to pull, right? But it's an administrative task, right? So it's not something that we're going or just like trying to query on the underlying relational database in the electronic health record. There's like a specific spot, or it's like for each of their these specific pieces of information. They have to have like one person in their agency who will enter all that in, right? And so it's not the ideal solution, but it's a solution that helps us collect what we want. The problem is that what you really want is sort of access to like the full array of information of the entire system of care. So that you're saying, oh, we want to know about this one particular thing, like we want to know about Latino penetration rates. And actually, we want to know about Latino penetration rates for this age group, right? Or for this gender, or in this zip code, or what have you, right? And that's something that would take longer to build out each time, right? Because we're trying to assemble these data from different areas, right? So we have mechanisms in place to collect specific pieces of data. So we have the results-based accountability framework, where there's certain elements that contractors are required to report out on as a part of their contract. And so we capture that stuff. And then there's other pieces that we put together in different ways, but it's just not, it's not as robust and fluid and flexible as we would like for it to be. And so the goal is to move towards that in one way, shape, or form, either by having everybody in our electronic health record. There may be another potential, like something like a business intelligence tool that is able to export data out of their electronic health record and into our electronic health record. That's very complex. And part of the challenge with that, even though it's not necessarily something that would be off the table, is that as the state changes things and continues to push out new initiatives, we have to modify the electronic health record, right? So a solution like that would require us to modify our electronic health record, then to modify their electronic health record, and then the intermediary would have to capture that as well. So all that to say,
The electronic health record, to me, it sounds like it's all of the geographical stuff and all of the gender graphic stuff, including the case notes and all that, that would be about the person. So what are we looking at on those reports? Like, is when you talk about the whole case, the person's, healthcare case or whatever, are you talking about gaining all the information on that person, or just
we
like
would,
some of
we
the
would
stuff
want
right there
every,
that you need from the state? Like what encompasses them when you talk about that record?
well,
Being
what's that?
imported over, we talking about the person's whole history?
Ideally, we would want everything. You know, we would want everything to be in one data set, right?
That's a lot of information, I can see why it would be.
Well, I think what Tony was trying to say, well, ideally what we want is all of our contractors using our electronic health record when they're billing for the services we're contracting for. Not for all of that patient data, not for all of their health records. This is specific to our Medi-Cal delivery system and for the services that we're contracting with them for. And so when we're talking about uploading data, it's different types of data. It's data regarding the services they've received, what type of services, the dates of those services, when they first requested a service to when they got it. So it's that kind of information, but the ultimate goal is to have one electronic health record. There's a lot of reasons why that would be advantageous for billing, for quality management purposes, right? When we do chart audits and chart reviews, right now, it's a very difficult process for providers.
Right.
Yes, yeah, for coordination of care. So there's a lot of reasons why it's the right way to go. Many counties have been doing it for a very long time. Just never.
So they can
And
see us.
so there's been a lot of
They,
strengths to it, I will say.
the only thing with
It
this, if I
definitely
move this
has
over and
resources
share it,
to
something's
support
not working and then she can't see it for the presentation.
Paying for a number of staff.
Carleen, it won't be on this screen, then these people will be on the screen. But they should be able to see because I'm seeing that it's showing.
And so the
You just
data
can't
that
see
we
them
put
because
in
they're not
for
up there.
a lot of
It
them,
says
the
that
kind of
they can't
service
see
they
us.
received, the billing code
I
that
don't know,
was
maybe
used,
because the
date of
presentation's
service,
up,
it's
but
that kind of
I'm showing that it
guidance,
is
that
visible.
kind of information.
So that's
It's
something
not
new.
necessarily.
Linda
this one,
is joining.
the
There was
entirety
something wrong with the link, so I resent the link to everybody.
I got the link.
Okay, good.
Yeah, no problem. I can see everybody at the table.
Oh, Linda says she can see everyone.
Yeah, it's not, it's around the same cost as we pay for Avatar. The cost is not substantially different. In fact, I think, well, it depends on how many users you have in it, so it can be a bit of a moving target on what the annual subscription cost is. The dilemma is the workload to get there, right? Is developing the systems and processes we need for entirely the electronic health record and then transitioning to that. And we would have a time period where we would need to have 2 electronic health records up and running. So there would be a time period where we would have to pay for Avatar and for Smart Care. And our MHSA revenue and budget is not looking great. One potential opportunity though, there are a few counties that have submitted an innovations plan to the MHSOAC to joining Smart Care as an innovations project, and it's been approved. And we have innovations money that is unallocated right now. So if there is a possibility that we've discussed potentially developing an innovations plan around joining this semi-statewide electronic health record. And being able to tap into our innovations dollars before they go away, because when Prop 1 gets implemented in 2026, our innovations funds that are set aside will just get pulled into the larger pool of our MHSA funds, and they won't be dedicated to an innovations project anymore. So we have about 2 years, just under 2 years now, and that's probably good timing for us to think about leveraging those dollars for this project. So it's certainly something we're considering. We have a meeting, a follow-up meeting with Smart Care. It's unfortunately not until October. They're quite busy with the counties that they're onboarding, but to go through some business process questions that we have, just to clarify a few things before we're ready to make a decision. But it's certainly something we're seriously considering. Yeah.
Because care force, I mean, that's.
Absolutely.
Implementing that and. There's gonna be so many different things going on.
And we need our system to work for us, right? And right now I think it feels like we're fighting against our electronic health record all the time. And every time we have an audit or a review like this, it's sort of a painful reminder of how inefficient and deficient, the system is for us currently. And so there was just some history, or there's a lot of history around this with the agency too. So I bet you do feel hopeful moving forward.
Just, I think one last
Yeah.
piece of like optimism about it, right, is that there's a potential, it's not a promise, but there's a potential that if we were able to migrate to a different electronic health record, and we're able to capture all the data from the other electronic health records, simply, we might have a better idea of like looking back retroactively than we're currently able to do, right?
Yeah.
So if we want to,
Give us more accurate
we want to try
data.
to trend data or certain things like that. We would on a systems level, we would potentially be able to do that, right? Or now we're able to trend some data, but not others.
Okay, move us along, we're only in the first review, we have 3 of them. The sixth opportunity, yeah. The sixth opportunity, it's the one that gives us the most valuable feedback that we can actually use to help improve our system. So I think it's a good one for us to be spending time on.
And it incorporates feedback from all levels of the system.
Yeah.
It's the only review that does that,
Yeah.
so.
The audit from DHS, they don't include clients, and so, yeah.
Or staff.
Exactly. So the last was, the 5th one was around our peer support workers. So, what the, opportunity for improvement said was that while as a mental health plan, we have a robust cadre of peer employees in both county and contracted provider programs, there is a lack of intentional supervision and support, as well as an understanding, I think of, like, for the staff of the peer employees job description. So opportunity for us to clarify and do some work around the classifications and roles of our peer support workers, and to build out a stronger supervision and support system for those peers. Right now, they're integrated into teams. So we have like peers on our access team, peers in our wellness center, peers in our crisis team. So they're being supervised by the clinical supervisor of that team. But I think where there's a real opportunity here is to have a stronger and intentional set aside supervision and support system specifically for peer support workers. And we do some of it, but we just can do a lot better. And then the other piece is around this new statewide opportunity for people to become certified peer support workers. And so we've done a lot of work to try to open a pathway for our peer staff to become certified. We cover the time they spend, in the program and doing the testing, we pay for it. And we've even done it for some of our contracted providers. But what the EQR noted in their feedback to us is that there's no real incentive for our staff, our peer staff, to become certified. It is a pretty intensive process, right? The studying, the preparation, and then the testing. we have some folks who are pretty anxious about something, and so even the process of signing up for something where they know they'll have to take a cut. We have a lot of peer supporters who are like, no, you know, I just don't, I would rather not. But there's no financial incentive for them to become certified, so at this point, you only have one classification of peer support worker, so one of the things that Sam and I have talked about, and that we're going to try to work with county HR as soon as you have a county HR director, we go without one for some time. Is around potentially building out a second classification for peer support workers, so we could either have a peer support worker 1 and 2, where the 2 is certified, or a certified peer support worker classification, where there could be more pay associated with that role, and we also potentially hopefully could offer full-time roles for those who that makes sense for. For a lot of our peer staff, they prefer to work part-time because of their benefits and other things, but for some, they would want to work, you know, in a more full-time capacity. And this could financially, I think, incentivize the certification process.
So I think you're exactly right, like the victim, what's in it for me?
Yeah.
And these are people, like any of us, like, I think it's law enforcement, I gotta take the best. That population is probably a little anxious about that.
Sure.
But also, I mean, I've been disappointed trying to understand all the balls that you guys have in the air with a lack of focus on the peer support workers, because, you know, statewide and nationwide, everyone's saying how important these positions are, but doesn't seem like, you know, from the HSA level and across many counties, some are focusing on them. There's no focus on them, like there's no, they don't get benefits, they can only work part-time. For a lot of them, I think, they wouldn't work any more than extra help part-time, but some would.
Yeah.
And these are people that do a good job and are important, as we've all said.
Yeah.
And I think it's really great that you're kind of trying to focus with everything else you have going on.
Yeah.
You know, on trying to get some positions so that for those who do want to be, you know, permanent.
Yeah.
And full-time.
Benefited,
Benefited,
yeah.
you know, you know, again. I question whether, and this is just, I'm thinking out loud, whether. You'd have to be whether you should have to be certified to go full-time, because some people that could possibly. Do a great job being permanent full-time, you know, maybe they can't even pass the test, I don't know, you know, I mean, but that's just something to think about.
Yeah, and one of the, and sorry, I know there's. Yeah, so you have to be certified in order to bill Medi-Cal, and so I think part of what we're trying to work on is also creating a sustainable financial path forward. Because right now, I will say, we heavily rely on the Mental Health Services Act funding to fund all of our peer support workers. And there's no reimbursement for any of them because they don't, we only have, I think we have 2 certified peer support workers right now, but I don't think either of them are billing quite yet. But we have 20 something peer support, we have a lot. And so only a fraction, right, of our peer support workers are certified. And so the one of the incentives, certainly for us, right, is being able to generate the Medi-Cal revenue. But that would help us to build out a financial model, a budget for this program where we could, I think, offer more. And so I hear you, I agree, and I think that for the full-time positions, you know, I can see us needing some certified folks in those positions.
That makes sense.
And those are maybe also the folks who might be more likely to eventually move into a behavioral case manager position, so it becomes a career ladder for them as well, you know, and that's an important piece for us too, is helping build those career ladders, because for some, peer support worker is sort of the ceiling, and they may not move beyond that, but we know that, and that might be because that's what they want, but for some folks, they eventually are really ready and able to take on more and to step into more of a you know, more of a less of a paraprofessional. Yeah, and having a career path. And so, you know, whether it's then stepping into a behavioral health case management position, whether there's eventually, you know, other systems of support for folks to then go back to school and get their master's degree. And we are doing that with actually one of our staff right now, doing some support for that person to go to school and get their degree. But those are the kinds of things that we really need to build out more.
I went to the health committee and testified 3 times to get the legislature to pass this.
Yeah.
This thing,
Yeah.
so that they could actually be
But we have the mechanism now, and now we just have to do our own internal county work, I think, to build out the classifications and just the organizational structure and support structure to also make sure that they're successful, because we also have had where we've had some peer support workers who have really struggled, you know, and had some decompensation in their own mental health symptoms and needed some stabilization, and some who couldn't continue on as a peer support worker because they need to address their own mental health. And so, and I've heard feedback across the state from other counties that have maybe more robust peer programs too, around how important that piece is, because folks can get very triggered, especially when we have peers who are going out and working on our crisis teams,
Yeah.
right? They're responding to crisis
Yeah.
situations, and sometimes you don't even know what you're going to walk into, and it can be quite triggering. And so, for anyone, not just someone, not just a peer support worker, right? What I'm saying isn't exclusive to peers, it can be triggering for anyone, but we certainly wanna pay extra attention and provide extra support to make sure that they are able to do those jobs and to feel supported and healthy in doing those jobs.
Maybe, I was just gonna say, well, maybe it is a good idea then to have them certified to be permanent, so like there is an incentive and,
Yeah.
you know.
Yeah, and then they can be a bit of a lead too and help support the peer support workers that aren't certified, so I think there's a lot of opportunity there.
My question is, I guess like, where are you recruiting peer support workers and what demographics do they kind of?
I don't know if I can speak to any demographic, I'm not sure what you mean by demographic, but we have an open recruitment on the line. I think some of our peer support workers come from our own services and system, right? So some are consumers or former consumers of services. I don't know, Sue, do you have any
I've
other?
never seen an advertised before.
Yeah, we have it posted online all the time as like a recurring, I think, or we have had it for a long time as a recurring extra help recruitment. So I think some folks come to us because they access services themselves. Some of our support workers are graduates of some of our collaborative programs. Word of mouth, yeah, some of our peers may tell other folks that they know. And I don't know if there's a particular demographic. We have men, women, we have younger folks, older folks, you know, and then we try to match peer support workers in the work they're doing with what would be a good fit for them. So, you know, we have a peer support worker who was a former worked in fire previously, right? And so that individual has done well on the crisis team, right? But then we have other folks who are a much better fit for the wellness center, where they don't drive, they don't transport, they're in sort of one stable location and they provide some support and everything in between. We have peer support workers in our Department of State Hospitals program, in our collaborative core programs, and so we really try to find folks who have their own lived experience or interest, right, in the specific kind of work, because that job can feel very different when you're working in a wellness center versus on a crisis team versus working on a Department of State Hospitals team, for example.
We have peer support folks.
Yeah, so I think the one thing that we had that was specific for peer support for that was, well, I don't know if it's considered peer support, but we did have the Promotores program that was through the CREO program, which is unfortunately sunsetting because of MHSA, but although they're actually not sunsetting those positions, they have other funding for them, but our funding of those positions is sunsetting. We don't have any specific, I don't think we recruit specifically for. But I think that's a good, I mean, I think as we're thinking about penetration rate, as we're thinking about some of these recommendations. You know, what is it that we need to engage with the community? We do a ton of work with, for example, the farm worker population on our social services side, right, around food security and housing and things like that. So I think there's a lot of opportunity to blend in some of our behavioral health services and engagement that we might be missing right now. Yeah, but the social service is strong, right? I mean, we have like a program coordinator that's dedicated to food security for our farm workers, right? And that is very specific, right? And that is pretty robust. So I think there's some opportunity.
Yeah, I mean, about kind of expanding on this work, so, as someone that's taking
Cal, there's a specialist class, and there's a lot of people interested in peer support roles that aren't necessarily aware of where to find it. And that makes sense, like there's a lot of people who are like going through that training and interested, and the thing is like, there's that gap in terms of like, hey, where can I apply this at all?
Yeah,
So I think people are just like not aware.
yeah, that's a really good point of that.
Yeah, so then, like there are certain certain agencies that are like training people, like for example, like Cal Voices.
Yeah, right.
It might be helpful to connect.
To advertise with them.
Yes, to advertise with them, or connect directly to those agencies so that you have a pipeline of like peer support workers that are applying.
Yeah, thank you, that's a really good suggestion, having a job order. Because all of our, I mean, all of our contracted providers are employing peer support workers in some way, shape, or form. Our children's providers usually are hiring for like family, you know, like maybe parent peers, you know, but in our adult medical, in our FFP program, they rely heavily on peer support workers. So, there are a ton of opportunities out there, but to your point, you know, it's like folks don't know where they are.
Yeah, I just keep, I mean, we stuck on this thing about them having to take a test. Because
Yeah.
It's like this, it's such an obvious
Only
barrier.
for certified though.
Yeah,
Yeah.
but still, I mean, these are, the people who come up with these rules, are the people who should be most attuned to that being problem. You know, like, has there been any motion towards like saying we need accommodations for certain.
Sorry.
sizes?
And it's, well,
Having an issue with Oscar saying he's trying to log into his hearing. I resent a link. The link was incorrect. It doesn't.
Okay.
It's wrong. He did, there's Oscar. There he is.
It was
Thank you.
very laborious, it was very challenging. And I've heard it likened to some of the certifications that we get in terms of like professional licensure or like becoming a certified addiction specialist, or like it's like bona fide true, like, I mean, it's a certification program so that you can become certified to then bill Medicaid. And the rate of reimbursement ends up being equivalent to somebody who who's either a mental health rehabilitation specialist. So it really is a very intensive training program.
But can't they replace that with the? Well, I mean, I'm used to getting accommodations for my kid, and so that's what I'm thinking about is there has to be somewhere that they can do something else that would.
If you bring up a good point, I mean, I think there would have to be advocacy at a state level, because this was determined, this was implemented at a state level, but I think very good point, very valid point.
And I think also,
I don't know what kind of current accommodations might be offered around the testing. I'm sure there probably are. I mean, they would have to, that's part of the ADA requirements, right? I mean, you would think, I would hope. But in terms of having an entirely alternative way of becoming certified other than testing, I don't think that exists. And so I certainly need to bring up a fix like that.
this is even barriers in the initial training itself, because there's an application for it, and then they require you to take a 2-week shutdown in your life.
Yeah.
And then I take the training, so then really people that are like already working on going on, it's like a little hard to do. Even if they would kind of try to accommodate these Zooms only like half days, it's still a 2-week chunk. They require people to be available, and then homework too.
Right.
So not just class time.
It's intense.
It's, yeah,
It is.
yeah, big word, yeah.
Very informative. It talks about, I would just say about like advocacy and policy, it is pretty broad,
Yeah,
but yeah, it's intense, I can see how that in itself could be a barrier.
Well, I just wanted to remind you guys, I think Monroe is either support people that want certified, so the HOR County, but.
Yeah.
Yeah.
I think 26, I think we have 26.
That's amazing.
Yeah.
And the ones I've seen, like in the cloud reports, you know, they're doing some good work and getting, a sense of accomplishment and also really contributing.
Yeah.
In a big way.
Yeah.
So that's good shit.
Yeah. Okay, and then the last was just that we were unable to submit a clinical kit. We had some pretty significant staffing issues in the unit that helps guide our PIP process, which is our quality management. We had a 40% vacancy rate for almost the entirety of that year. And then we had incredible workload demands with Callie and perform, and so we did not do or submit a clinical PIP. So that recommendation, of course, was that 321. So all of the recommendations, and Christine, if you just go to the next slide, each recommendation is tied to these opportunities, and so the recommendations to implement strategies to increase Latino specialty mental health penetration rates. Implement a new methodology for timely access tracking and routinely review the data for accuracy. Also, research barriers, design and implement processes to improve timeliness for non-urgent psychiatry and non-psychiatry services. That was inclusive of adults, children, and youth and foster care. The next was to develop an operational plan to utilize the health information exchange. And then about how to work with our contractors to resolve some of the operational issues to get access to our EHR. So really recommendations are on getting them there. Create a protocol and implement a system that provides intentional supervision and support to care employees. Move forward with the plan to develop 2 employment tracks and job descriptions for peers that recognize peer certification and compensation. And then the last recommendation was to design and implement a clinical fit for the current year, and we can engage with the EQRO for assistance in this process. Unfortunately, the Department of Healthcare Services is no longer contracting with Behavioral Health Concepts, with the EQR. They contracted with a new organization who hasn't started doing external quality reviews yet, and so I think we're gonna have a gap in this process. So I've heard, I don't know if it's final or not, that we likely won't have an external quality review. And then we'll get the year maybe, and then they'll start. Okay, moving on, can you go to the next slide, please? The next was our Department of Healthcare Services engagement audit. This previously was called a triennial. It's an audit we have every 3 years. This is the absolute most resource intensive of all of the reviews that we'll discuss today. It is a very in-depth review of our specialty mental health system, a review of our drug medical health organized delivery system, and of the substance use for substance abuse block grant. We've changed the name recently. And I just put on here, these are just the categories of things they cover. For each of these categories, we have to have analysis of evidence, policies and procedures, contracts, documents, agendas, minutes. And then there is also a chart audit component that they do. And so some of the things they review are network adequacy and availability of services, care coordination and continuity of care, quality assurance and performance improvement, access and information requirements, coverage and authorization of services, beneficiary rights, and protection and program integrity. And that's just for specialty mental health. So our team prepares for months for this review. Our quality management team spent several months working tirelessly to prepare. And then the review process itself is pretty intensive in having, they used to be also on site, they're virtual now, but virtual meetings, and they have specific topics that we meet on. They, I would say, ask us questions, but it's a little bit maybe drill us. And it's not the most warm encounter, I would say, but nonetheless, we persevered. Can you go to the next? Oh, sorry.
I would just add that there is no way to over exaggerate what are saying.
Yeah.
Right?
Our, and I have to put a plug in to our clinical management team. Jennifer Day, and the clinical manager, did an incredible job, new to her role, and her team submitted over 1,000 documents to support our plans for this audit.
Yeah.
All
So they review so much information. It is very intensive. And I will say, heading into it, we were quite anxious. This is reviewing a time period of COVID, when it was like we were just trying to get by. We also had a pretty big leadership change in the middle of the time period, Karen leaving and lots of turnover within our branches and within our systems of care. So heading into this, I think I felt quite anxious about what how this audit might go. And I've been a part of triennial audits in another county, and we had one right as I was starting here in Yolo as well. And so and we've had that gone very poorly here in the past, where we've had a large number of disallowances, where we've had a large number of
From 3 years.
That's right. Where they're taking back quite a lot of money for services that then they disallowed after reviewing targets, and from our contracted providers or from us, but ultimately we're responsible, right? So nonetheless, we had very minimal findings. I am very proud of our. Absolutely. Yeah, I'm well aware. Yeah.
It was caused.
I work for one of our contracted agencies. So the first finding is one that we absolutely knew we were getting, and that's that we're not currently providing therapeutic foster care, so we talked about it a bit here, it's a very difficult benefit, it's one I'll just say I fundamentally disagree with, and so I do have. Tony and I are rallying up some other counties and CBHPA, and I think we're gonna kind of go ahead and kind of CF on it a little bit. A lot of counties have been implementing CFC for years now, have data that doesn't really support that the juice is worth the squeeze, so to speak, right? For example, San Bernardino County shared that they've been offering TFC for 4 years. They've had 14 individuals access services, 14.
Is that because they moved so much and changed?
It's very difficult. It's a very difficult service. The foster family agencies are hesitant to actually have TFC homes because then they think that the foster family is their employee. The foster parents will not write progress notes to bill for services. Lots of different issues with it. Sometimes the parents get burnt out after even just having one kid with them, and then they need to take a break from doing foster care altogether. It's also fundamentally flawed in that for children in the foster care system, this is an easy service to access, but for children who are not in the foster care system, there is no payment mechanism to pay for any kind of board and care rate and kind of placement rate for them to be placed outside of their parents' home. And so the benefit by itself isn't enough to cover the cost of living, to having another child living with you. So it is, anyway, it's a flawed benefit. Nonetheless, we've issued an RFP, it's open now, and that's on my director's report. But our first 2 findings are. The first is that we were not offering the service, that is accurate. The second is that we were not ensuring the assessment for the need for services, so that we weren't screening children need for the benefit, and that's because we're not offering the benefit. And so we will submit to those findings and submit a plan of correction, which is, you know, that we're doing the RFP. I don't know that we're gonna get any responses to the RFP. The appetite to do the service is so tiny, the cost we pay. But we're gonna do our due diligence and do all that we can. Tony, did you wanna say anything?
I just wanted to add that there's one other, I mean, I got lots to say,
I know.
but there's one other element that is, just, FFAs in general right now are really in a dire predicament.
Foster family agencies.
I'm sorry, foster family agencies across the state of California are in a predicament right now because most of them are insured by one, particular insurer, which is the nonprofit insurance agency. It's NIAC, and essentially what they're saying is we're about to stop trying to foster family agencies that the fact that there's a significant lawsuit, legislation which allowed former victims to come forward and file lawsuits with no statute of limitations. So long story short, on the child welfare side and on the behavioral health side, with regards to this piece, foster family agencies are already having a difficult time being insured if they have a pool or something like that. Anything that would increase the liability of that child. We have certain foster family agencies who refuse to serve children who have a history of fire setting, right, because of the insurance. And so we're talking about serving youth who have some of the most significant mental health challenges and behavioral challenges. And we do not anticipate that foster family agencies are going to sign up for this, right? So absent that, we would be trying to individually license specific foster homes, which would be a very intensive lift for us in terms of like training and maintenance and everything that goes along with that, right? So there's a lot of fundamental flaws with just the way that it was rolled out and the philosophy of it in the first place, and then there's some real world context that is making it very unlikely that any FFAs are going to come forward and respond to our
We'll continue to get findings from the state. You know, we'll have to report our progress. We're trying to do it, you know, we'll be on a plan to improve. And we have to report on that.
I can't, I got 2 minutes going on.
Give up.
Sorry.
They could technically impose fines and sanctions. I mean, that is part of, they have not, to my knowledge, imposed fines and sanctions on any county related to TMP. And I think this is why at a higher level, I think it's timely to do some advocacy with the state around this benefit and around, you know, I mean, it was very unfortunate because we had a section around our children's system of care. for this audit, they spent almost the entire time talking about this benefit, which was such a disservice to the rest of our system of care that's doing so much good, right? But they focus so much on this one thing that we're not doing, that we didn't have an opportunity to really talk a lot about the really wonderful things we're doing. And so, I think we have a variety of counties that have implemented and who are experiencing different challenges, and so I think we have a good representation from the state, very large county, a very wealthy county, a county that hasn't done it, other county, right? To come to DHCF and sit down and really have some conversation about the benefit and how I don't think it's achieving what they intended, right? And so I'm hopeful that we can give some feedback, I know there's some change in things, but because I think this was part of the KDA, somehow part of the KDA settlement.
Just something to get.
Yeah, and so it is, has a long tenuous history and quite complicated in terms of litigation and other things, but this one missed the mark, I think, so we're gonna do our best. And who knows, maybe we'll get a response and someone will say, yeah, we're willing to have a home, and we'll technically meet requirements, but then we have a whole lot of actual process and policy procedure to sort out. So, we've got some work ahead of us for this one.
So our schedule, so we're
Yeah.
about 15 minutes over time here.
I know,
I don't know how much, you might not have a lot of.
there's not a lot left.
All we have left is the mental health records report, it might not be a lot on that, but I just want people to be mindful.
Yeah, thank you. So I'll just put the only other two findings we have are related to our access line. And this is our previous provider. And so the first finding was that, that when they did a test call to the access line, even answered and talked to the caller, did not provide that person information regarding beneficiary problem resolution of their hearing processing. And so, so their recommendation is for us to implement policies and procedures and contract requirements to ensure that the staff is providing that information. And again, we separated from our previous access line provider. And so, I will say, I got a little protective of our system and our team, because in our exit conference, the auditor said something like, and the plan did nothing to try to rectify that, or it took no action. And I said, I am sorry, but that is not, that, I disagree, and that's not accurate. I said we've taken the most significant action that can be taken. We're not contracting with them anymore, and so that's not reflected. So we have an opportunity to provide a response, and perhaps they'll edit their report. But the reality is that this finding is based on old information from our previous access line provider. Not to say it couldn't happen again, right? But it does, I think, underscore the importance of ensuring that all staff are trained, that they know that when someone starts to say, I have an issue with around access or around services, that they're given information, right, around their rights. And about the problem resolution process. But from our perspective, this is as Nolan would say, it's a nothing burger. So, the second finding is also related to the access line, and that's that we didn't log the access line did not log every call. So same thing with our previous provider. And the recommendation is that we have policies and procedures to make sure that all requests are logged and meet reporting requirements. So we feel confident that we're doing better with our new provider and that we're implementing those policies and procedures now. Christine, can you jump forward?
All that to come up with those.
That's it. Those are our 4 findings. I mean, there were no findings for our drug medical organized delivery system, no findings for the substance use block grant. This is it. So this is, I think, honestly, I think the most glowing audit findings we've ever had in a training org. So I feel very proud of it. Right. Moving ahead to the MHSA audit. Let me get to the slides, then I can just read it to you. And Christina, if you have a chance to move it forward. The Department of Healthcare Services conducted a desk review, a virtual desk review of an extensive list of documents, contracts, reports, policies, and procedures related to our MHSA program. So we had about a month to submit all of those documents online. Our MHSA program coordinators took lead on that, so they had to work with fiscal contracts program to get all the documents they needed. It's a pretty lengthy list, I'd say hundreds, probably over 100 different pieces of evidence that were needed or document types that were needed. And there was one finding And the one finding is that we did not submit our fiscal year 2020 to 2023 3-year program and expenditure plan to DHCS within 30 days after adoption. So this was back in 2020, and it was when our plan was approved by the board. It was approved August 19th, and for whatever reason, I don't know why, maybe it's been just pandemic things, I don't know. We did not submit it to DHCS until October, so we were a couple of weeks late on the 30-day time period, and that is our sole finding from the MHSA plan. They did have two recommendations, and so those are suggested improvements. The first is that we indicate the number of children, transition age youth, adults, and older adults to be served, and indicate the cost per person for each innovation project and plan and update, which we are already doing now. So we didn't do it in the 3-year plan that they saw. That was, that was part of their review period, but we've been doing it for the last several years now. So we are already meeting that significant improvement. The second is that the county identifying their full service partnership policy and procedure, that a personal service coordinator, case manager, or other qualified individual knows the client or family is available to respond to the client or family 24 hours a day, 7 days a week to provide half an hour of intervention. That's a core sort of requirement of a full service partnership. I don't think it was explicitly stated in our policy and procedure, so they suggest us to, and their suggestions are not suggestions, they're direction. And so we'll be revising our policy and procedure and noting that to them and sharing that. So that was it for the MHSA audit. Any questions about any of that? I know we asked a lot of questions along the way. Okay.
Bravo.
Thank you. Bravo to our team. It's okay to all of our staff. Yeah, they're doing an incredible job.
That's on our kudos.
We will.
All right,
Thank you so
how many
much.
do we have now, logged on to
4, I mean 3.
3? Okay, is there any public comment?
Yes, I have public comment.
Christy, let me switch this screen over.
Hang on one second, Christy. You can put her on the screen.
Yeah.
Awesome.
Can I start?
Not yet. Okay, this is the speaker out of your computer, Christina?
Yes.
So speak up, speak loudly, outside voice.
Okay. Hi, everyone. Good to see you, and Supervisor Villegas, good to see you too. I read Carlene's mental health director report, and I'm just feeling like super excited, and your board is doing such great work, and it's just nice to see the progress, from 2 years ago and the strides. And I really want to call out when I read the report and I read item F, I like literally was like wanted to jump up and down. So I just because of our experience with my loved one and his mental health needs and the incarceration that he endured and how traumatic that was, and just everything around, like people that need services going into that jail. I'm just really excited that you're taking the time and putting the effort into looking at that contract with WellPath and making sure that the services are being provided and the needs are getting met, and assessments and evaluations and all those things, those gaps that I started calling out in 2022 in Board of Supervisor meetings, that they're actually being addressed. And, there's room for opportunity and, improvements to be made. And that will directly impact the lives of those individuals that are needing behavioral health services. So I'm just so excited. Carlene, kudos to you, just huge call out. Like, I was so excited. And I just wanted to take this time to really acknowledge, I feel your passion, and it's coming to fruition, and I can see it implemented. I know things take time, and I'm not a patient person, but I see it now. I see that it's starting to change for the better, and I just really, really appreciate all of your work, all of you in that room and the supervisors. And I'm feeling like you know, excited and I'm ready to champion, you know, everything else that you accomplish. So thank you.
You want to give an update on what's going on with you down there and?
Well, you know, so my son completed his MHC diversion program, and that's a testament, you know, to Chris and Jonathan's team and the whole HHSA team, you know, Terry and just, you know, Gregory, I don't like talking about him, but he's my son and I'm his caregiver still. So it's like, I feel like I kind of earned a right, but, you know, I literally wouldn't have him as healthy as he is today if it wasn't for, you know, him getting that access to Health and Human Services. And we didn't have that in the beginning. And it was messy and clawed. And like, I had to, you know, do all kinds of crazy things. I felt like bail him out to get a psych eval and like, just to get that access to care because, you know, he was coming in undiagnosed and from a managed care plan that wasn't, you know, Medi-Cal. So now it's like looking at 2022 and looking at now, like he is doing so much better. So he graduated, we moved down here. You know, I saw a lot of you at his graduation and, you know, we were off on our adventure and he's working full time now. I'll just tell all his business then. He's working at Lowe's in Carlsbad and he started as like a temp position, full time, but temporary, like not permanent status. And he's done really, really well. And they really, really liked him. He started in the garden section. So he would show up every morning at 5 a.m. and water the plants all day outside. And he just really put in a lot of effort. And, you know, he hadn't worked in almost 3 years, you know, through this process. So I think he was just really excited to have a job. And it was hard for us to get a job, honestly, because a couple of the background checks that they did came back with felony on it still. And so it was kind of discouraging at first, but Lowe's only did a countywide background check, not a statewide, so they didn't pick it up. But anyway, he got the job and they just offered him a full-time permanent position. So now he's in fulfillment. So now he went from a green vest to a blue vest at Lowe's. So now he works full-time and he'll get health benefits soon. And so when there's online orders, he runs around the store and does a scavenger hunt and fills the orders for customers. And he's good at it. You know, he's learning, he's kind of relearning skills like how to use software programs and things, but they love his hustle and his work ethic and he's getting healthier. So, you know, I'm on him. He's going to his primary care doctor. His diabetes is getting better and he's losing some weight and, you know, we still have so many obstacles to, you know, overcome, but I look at the positive, you know, I look at the progress and I look at, you know, where I try not to think of where would he be or where would I be, you know, if it wasn't for, you know, the team in Woodland at HHSA, like if it wasn't but for the FSP program, but for them, you know, intercepting him and taking him in and providing, you know, he needed to be, you know, in treatment and just him getting to be treated in the community. You know, I consider us the fortunate, you know, lucky few that get to do that. And it's just, you know, he's on a road, but you know, we have a lot of behavioral health stuff to work through and, but he's on a path and it wouldn't have been possible if it wasn't for this work that you guys are doing. So thank you so much. And, you know, I'll give you another update soon, but he's doing good. He's happy. You know, I can see joy in him again. And, you know, he's still got a lot of trauma to work out, you know, but it's so refreshing to see that things are getting better and that services in that jail. I think that's, you know, it's just a huge pain point for me is that they're getting addressed and looked at. And those people, to me, that are the most vulnerable population that need it, need treatment and need to heal, that they can get that access through your office. So thank you so much, you guys. It's good to see you. Hugs.
Thanks. And the Padres are only 4.5 back.
You know, it's just the Yankees are going to take care of it anyway.
So, I mean, Greg put in a heck of a lot of work. And he wouldn't be here, you know, without you as his mama bear advocate.
Yeah.
And
so many in that jail, and I'm sure there's still a waiting list. Carlene, I won't ask you how many, but I'm sure there's so many in that jail that don't have, you know, moms or loved ones or aunties or grandparents, you know, to fight for them. And, you know, they deserve help and treatment, you know, just like everybody else. So I'm excited for CalAIM. I'm excited for a lot of these, you know, initiatives to come online. And I've experienced it. I don't just see it and hear it. Like, I've experienced your work and I'm seeing it come to fruition and happen. And I feel a lot of gratitude for that. So
Thanks.
Keep-
Yeah, thanks for sharing. What Christy was talking about, this felony showing up, so it's a very nuanced thing. His charges were all dismissed, and if you think about it, that's how it should be. Because someone comes out of that program, they shouldn't have a felony hanging around their neck. But because of the way it's written on the minute orders and things like that, and the court documents, if someone goes through there and they don't know what they're looking at, and they don't really understand, they might think that he has a felony. And we actually had the judge change the minute orders because of this, but I just think that if it's impacting Greg like this, it's probably impacting many others, you know, when in fact, like I said, he had a deferred entry of judgment on a felony, but his charges were all dismissed, so he has a clean record. Anyway, okay, so thank you again. Any other public comments? All right, so we're moving on to the mental health director's report, and so items that board members want to hold, so Carlene can talk about them.
Yeah.
Yeah. Okay, yeah. Anything else? I'm gonna say B and E. Any others?
I was gonna say, we should come in now, so,
Which one?
A.
A. Okay, and Nikki, would you have, you said you wanted.
Yeah.
Someone said wanted one that I. If someone else. I'm just trying to.
It made me agree with you.
Yeah, which one? Yeah, which one?
B and the E, so.
B and E. No, so you can all know. Okay, so let's start with B.
Oh, it was a lot of numbers, and I didn't know if Carlene wanted it for our attention, or if it was just to show what was on the dashboard.
Yeah, a little bit of both, yeah, and I think Jonathan asked
I
it.
had asked her if she could do like a little short executive summary.
Yeah. Yeah, so it was a both, kind of both, right? Like, I think there's been a lot of talk here about outcomes, you know, and so it just felt like a good opportunity to show you how we use a program called Smartsheets, which is like Excel, but kind of on steroids. And we use Smartsheets, we're using Smartsheets now for our RBA, so this is what our dashboard looks like, when the data gets put in, and then it sort of can spit out this report. Now, there is a lot of numbers, a lot of charts. Sam and I were talking about, we think that we could sort of do some work to clean this up or spit out a report that has just some high level. Because some of the times when there's like both the number and the percentage, the number might not be as helpful to see as the percentage, so some of those kinds of things, right? So this,
Yeah.
like, this is the whole,
Hold on.
all of it. Oh. So you wanted to this is everything, right? It's like, this is the kitchen sink. So some of the things I'll note is that, we have had some pretty, long-standing vacancies on our co-responder teams. I think that's where you'll see some of the decline in the numbers, of folks being served, the numbers of responses. It almost, I think it's something like half, right? But, you know, previously we had 2 co-responders in West Sacramento, 2 in Woodland, 1 in Davis, and 1 shared between sheriff and probation. We, for a very long time, had only 1 co-responder in West Sac. We had 1 vacancy in West Sac. We've had both of our Woodland ones filled for quite some time, so that's pretty stable. We had 1 co-responder in Davis, and then we had a very long vacancy after that co-responder left, in a very difficult time filling that position. And then we've had some stability with our shared co-responder for sheriff and probation. So we were about a 40%, I'd say, vacancy rate there, maybe a little less, so maybe that's more like 30%. But that's pretty significant. And so I think we saw some significant decline in numbers there. We are fully staffed now, and we are looking to add a position for Davis. So the plan is that we'll have 2 in West Ave, 2 in Woodland, 2 in Davis, and 1 shared between sheriff and probation. I think the positive thing I wanna highlight here is that the outcomes, I think, are very tough, right? In terms of our contact that our co-responders have, we have a very low percentage of those folks who end up going to jail, right? A very, I mean, mostly it's 1% or 2% or 3% at most. And we also have a very high percentage of folks who are not placed on the 5150, right? And so I think it shows that we are able to go out, provide intervention, help de-escalate situations, and ideally prevent folks from stepping into those systems of care that we're trying to prevent that overutilization of the emergency department and jail, right? Even while we still don't have the receiving center quite up and running yet, we imagine that we'll really make big changes when we have that facility available for co-responders to drop off to. I think that, you know, we've seen some decline around some linkage to services. I think there's probably an opportunity for us to sort of strengthen some things there. And I think there's also some measures that show some consistency, like the average amount of time that a clinician spends on scene is just under an hour, and that's pretty typical. I think it had a low of like 40 minutes, but it's around 50 minutes, right? Most recently. And pretty low wait times for officer wait time for a clinician to respond and things like that. So overall, I think these outcomes are very positive. I think once we're fully staffed, we'll see those utilization numbers sort of increasing back up again. But again, we had long-standing vacancies, and those were co-responder positions where those had been really core sort of clinicians who were providing quite a lot of response, and so then to have no one, right, for David, we had no one, right, for quite a long time. So we were having to sort of fill in, but that doesn't always provide the same level of service. So I just mostly wanted you all to see it, to see what our dashboard looks like. This is specific just to the co-responders, so this doesn't track like AMR or after hours mobile crisis or anything like that. This is just for our co-responders. And I know that Tony, eventually when we do the children's presentation, he'll walk through some dashboards, similar dashboards for our children. And so what I'd love to start doing is doing more of this, right? Having more of like sharing this kind of data with you, or sharing those dashboards and what they look like, having some opportunity for discussion around it, and weaving it into presentations when we can, but certainly into my director's report as well.
Good, excellent. All right, Dee, did you have something to say?
You know, mostly I just wanted to join Christy in commending what you're doing in Virginia. That was the main reason I wanted to pull it, and I'm hoping that at some point, the new person will be able to come here and report back after they had a chance to find out. That was my.
Yeah, I mean, I'll just speak to that. I actually want to acknowledge our board, you know, and our jail medical contract is a general fund, primarily general fund funded contract. It's quite expensive. And we advocated strongly for a long time when we needed to have a coordinator overseeing this contract. It is I think, one of the most expensive contracts in the county, certainly the most expensive contract for HHSA. And it's a high risk, high need, you know, contract. And we've had poor outcomes, as we've heard in the past. We've had challenges with our provider. We've had struggles in terms of coordination and service delivery. And we eventually were able to fill that position. So we're thrilled to have someone full-time overseeing this work. It's actually a former HHSA employee who came back, and is a social worker actually, you know, by her prior work. Such a great fit for this. She's doing a great, she's left and gone to the private sector doing a lot of project management work. So really unique combination of skills. Her name's Amanda Ronsley. She was a child welfare social worker and a supervisor in child welfare for some time. And then she left for a bit and now she's back. It's been great. And so she's, you know, developing regular and different meetings, whether it's between HHSA and the sheriff's department or all of us in WellPow, really holding them to the line around their reporting and their response times to us. And then now they're gonna go out and do the jail monitoring and do that process in September. And so I feel confident that I'll have some data and reports that I'll be able to start sharing here. We're just working on really building that stuff out, so she's sort of building it all right now. And really starting from scratch, because a lot of this didn't exist, you know, not a lot of policy and procedure, not a lot of structure for this. And she just said the other day, I wanna build out the structures for this, so that if I'm ever not doing this job, anymore, someone can come in and can continue on this work, which is exactly what we need. She's been wonderful. I'm so happy to have her back in this role, so I think we'll have more to report, but just even the elevation, I think, of like the accountability and the consistency around some of this. I think we're already seeing some positive outcomes from that.
And maybe she could come to the committee.
Yeah,
That would be great.
yeah, absolutely.
Okay, yeah, Nikki.
Yes, this, I know it's not anything you can do. But if somebody's not competent, then trial. Why should you be?
Yeah, that's a great question.
Well, you say you.
I mean, but it
It's the
says.
county, it's
Yeah.
the county.
Yeah, yeah, so let me,
Go ahead.
was pretty involved in this, I was actually on a small statewide working group. The bottom line is, it's all about, a lot of it's about beds, just like with prisons, you know? The vast majority of the beds are taken up by this ISC population, which is kind of, for lack of better word, kind of crazy. Because, you know, you send them into the state hospitals, you get them well, and then you put them on trial, like, or you do something different, you know, which doesn't seem to make a lot of sense anyway, but that's a whole different story. But, I mean, sometimes it's necessary, but, like, I've seen the presentation from DSH many times where they talk about, this is not only statewide, it's nationwide. The logarithmic, if that's the right word, or was it, you know, increase in ISTs everywhere, okay? And lack of bed space, okay? So because of that, there were these huge waiting times, okay? People would be sitting in our jail, IST, needing medications, for months or up to a year, waiting to be transported, okay? And that caused major issues. There were lawsuits by mostly the public defender, which the DA stood behind, because we, you know, we don't usually.
Yeah,
But they were advocating.
That's not your usual.
They were advocating for their client, and we were like on the sideline supporting their, you know, and they basically, some counties, including Yellow, set a timeline of like, I think it was 90 days, different counties with different timelines. They didn't meet those goals. Public defender filed orders to show cause to basically fine. The judges were getting really, really frustrated with DSH. DSH was kind of not moving as fast as you might hope they would, but they were in a tough predicament because they're not going to build more beds. And finally, there was a lawsuit out of Alameda, which went statewide, which said they have to have, you know, people out within a certain amount of time, else they're going to face significant penalties. So they were trying to figure out what they could do to kind of solve this issue. So I think what they did was well intentioned. They basically said, okay, you're sending too many people here IST, okay? And a lot of people they send there, the moment they send them and they get them, they're competent. You know, so that maybe they didn't need to go anyway, maybe they became competent while they were waiting in our jails, who knows? But so finally, they set up this penalty, which really, the way they did it, made no sense. They didn't consult with any of us. It was like during a period of COVID, it
Snuck
penalized.
it into some legislation that no one really
Yeah,
fought, and so.
It penalized the counties that were doing really, really well, because basically,
Our
you had this
baseline
baseline, and if you had a really high baseline, that's
You
good.
got more than that.
That's good,
Yeah.
anyway, if you had a low baseline like we did,
Too bad.
you got, you know what?
Well, they also used 2020 to 2021 as the
Right.
baseline, which was COVID
That's, yeah,
time,
yeah,
so.
exactly,
it was
exactly.
a horrible
So-
year to use for.
You know, there were lots of discussions about how we could solve these issues. And then they set up this Department of State Hospitals grant, which is a great thing, where they fund a lot of money to us to have counties, if they wanted to have like a mental health court focused on this population, which was really good. But the bottom line is, we actually, were one of not that many counties for that first year that were over. There weren't that many, and we were one of them. San Diego was like millions and millions and millions of dollars. And San Diego has really good programming, their jails, their systems, like really good. But it was all because of the space line. So, now we're into a different year. When I was looking at the numbers, I was following them when I was still there, and they didn't look that good. Like, because I would watch them and multiply them in the first quarter, okay, multiply that by 4. Wow, we're gonna be over second half of the year. So I'm kind of surprised, pleasantly surprised, that looks like we're not gonna be over.
We're over by 2, but the way the formula works is that because we we have a number of sort of like exceptions, the way the formula is set up, you only start to get penalized if you're over by 5 for this current year. It changes as time goes on. And so we were over by 2, but that doesn't result in a penalty. We were penalized the first year, $420,000.
Yeah, and I will say, what they conceptually, they had kind of a good idea. The $420,000 goes back to the county. So the county has to find that money somewhere, the whole county. The $420,000, I don't know where that money came from, because I left before they decided we were struggling.
It's 4 letters and it's an acronym.
Yeah.
HHSA.
Well, but then they give you back the 420,000, but it's earmarked to spend on programs.
It's sort of a force, like
Forced savings.
investment savings,
Yeah.
right? So it's like they make you identify county dollar, any kind of local dollars. To pay the penalty, you send it to them. And then they send it back to you, but you have to spend those dollars on a program that you've written into a program proposal to them that is intended to help reduce, eventually, to reduce the number of people who are found incompetent to stand trial. And there are a number of categories that you can build programs out of. So it's sort of forcing you to invest local dollars into a program to prevent them from getting more folks who are determined to be IFT. And so we were penalized the first year. About $420,000. We just got the invoice a few weeks ago. They've already asked me where our payment is. It's not due until September 19th. But we are going to use some of our investment dollars for the Crisis Now Receiving Center as our program. Because if you divert people from jail, then you are diverting people from becoming incompetent to stand trial, right? And so that's our intention. So we could pay the penalty here very soon, and then we'll get the money back, and then we'll invest it in the.
Well, and that's $100.
We're not using MHSA, there's other dollars, it's a combination of funds.
Can I ask, why does it have to be the state hospital? Why couldn't you use IMDb? A locked, facility.
Well, first off, the whole point is that they're
I know.
getting treatment to be restored back to
Restored
competency. So they, the IMD, it's not like there are any beds there, right? IMDs, there's no beds there.
Well, but the difference, the difference is that while they're not gonna build more state hospitals, because Ronald Reagan decided 50 years ago that we needed to close all the goddamn hospitals. And wasn't that a cheery choice? So they're not gonna build more hospitals, but IMDs are privately owned. And so if there's a demand, there will eventually be a supply. And so it just seems to me that, and I understand the whole thing of, oh yeah, play crazy, and then they won't be able to try you. It's pretty dreary being in one of those places when you're really not sick. I mean, it's not a system I want to be getting in all the time. So I'm just saying, there ought to be a more constructive way to resolve this. That doesn't involve taking money from agencies that are trying as hard as they can to deal with the budget as it is.
Yeah.
And to change it from the right pocket to left pocket.
Yeah. It does. Well, it does, but also, sometimes the DAs are wondering whether people really are incompetent or whether, like.
It's two different things. I mean, if there's really a question about it, then yeah.
But it doesn't incentivize us, it only incentivizes us to fight it at a high level of it's costing the county money. Our deputy DAs, they don't give a crap about the fact that it's costing the county money, right? Deputy DAs are kind of making those decisions with supervision, but they're not focused on.
They're not pressured to do it.
No.
Looks like Oscar has his hand up, just so you
Oh,
know.
Oscar, I see your hand up. I thought that was like a little crown.
Was it? I couldn't tell if I put my hand up or not. Sorry, you guys.
Go ahead, Oscar.
I just wanted to simply say I actually share Christie's enthusiasm. Thank you guys so much for your work. The work that we do oftentimes does take a little bit of time, but I think some of the work that we started years ago is coming to fruition. That's number one. Number two, today we had the opportunity to give a tour to the chair or the president of the State Association of Counties. He's a supervisor of San Luis Obispo, and he got a tour and got an opportunity to hear the crisis now and all the work that goes into it. Staff did a wonderful job of presenting on that. And he privately said, you got just some bang up staff. You're very lucky. And YOLO knows what they're doing. So we got kudos there. And then I'll just simply close by saying, we really do have to be careful because we already know what the state is doing in terms of the budget. So we are a reflection of the state's budget. We have to watch every nickel and dime. And so we're starting to tighten our belt. And so the decisions that you guys make are going to have huge impacts for our communities, but we're going to have to work hand in glove to really make sure that we're watching every nickel and every dime because the budgets are going to get tighter. We already know that. So that's my long and short summary. So thank you guys so much for your willingness to serve.
Well, thank you, Oscar, and we always appreciate it when you join us, so thank you very much. And I can't think of a better way to end it on that note, hearing from Oscar and Christy, and we're actually finished with the agenda, so we will adjourn. Our next meeting is on the 4th of September, back in Woodland, and it is 8:01 and we're done.
You did good.
Yeah.
So, should I email you? Yeah, I can out, check our calendar. I'm gonna be so.
Dave?
I'm actually out on like. Yeah. I want to take the part. And I'll send it out to people that. Okay, I'm gonna be out next week too, so.